hit record. And we're going to go ahead and see if I can. Alrighty. So I went ahead and I shared my screen with everybody. If you can go in the chat bar and let me know if you did not see that come up. If you did not see a presentation, if it's not on there, let me know. But I'm going to go ahead and get started. So, unlocking weight loss strategies and medications. Again, these are the medications that we tend to use. A lot of the strategies have really come from the experiences with a lot of our patients. And so really try and individualize what we do as much as possible. There's a lot of cookie cutter stuff that we can do, but at the end of the day, we do have to try and individualize things as much as possible. Again, not everybody is going to have the same needs. Not everybody is going to have the same, the same stuff going on. So, let's see if it, okay, yeah. So, and I didn't really want to dive deep into, obesity and all the demographics that are out there, but, it really is a new epidemic. But what often gets missed when we talk about obesity is that we are looking at specific numbers, and there are other risk factors and things that we actually fail to address. And so a lot of times we're addressing things like obesity and diabetes when they already happen. We try as much as possible to be proactive and start to address those things even before they happen. And again, so for a lot of our patients who are on weight loss medications, they actually may not even meet the definition of obesity because we are trying to get in a lot earlier and address things before things even start to get out of control. Again, so all of us would love to have well-built bodies. And honestly, we have the right to think that, right? But again, like I said, obesity and what we sometimes see in a lot of people, which is abdominal obesity, where just the fat is along the abdomen, is not just cosmetic. There are a lot of health risks associated with it. The following conditions have actually been implicated in what we call peripheral adiposity, or accumulation of fat in the skin, typically around the abdominal region, as well as in frank obesity, so type 2 diabetes, high blood pressure, and typically stroke tends to come as a manifestation of both high blood pressure and type 2 diabetes, as is heart disease, gallbladder disease, osteoarthritis. Again, that's just wear and tear on joints. The heavier you are, the more strain you put on those joints. Again, unfortunately, the skeleton that you have today will not increase in size to accommodate greater weight, and so you end up having more stress and strain on those joints. Poor wound healing, sleep apnea, certain cancers have absolutely been linked to obesity. It's a little bit more complex in terms of how that happens, but there's definitely that relationship, as well as depression. Like I said, there are various ways that we determine what obesity is. The standard calculation has always been what we call the BMI. This takes into consideration your weight in kilos as well as your height in meters to come up with a calculation. Now, one of the issues with the BMI is that it doesn't take into consideration muscle mass. So you will sometimes see very muscular individuals in the office who have a BMI of over 30. And again, 30 is that benchmark for obesity. And again, one of the problems with focusing just on BMI is that a lot of people don't get treated, maybe like at a 29, because they're like, well, you're not 30 yet. Let's wait until you're 30, then we'll start to do something, which I think is the wrong approach. And so again, clinically, it's diagnosed with anyone who has a BMI of over 30. We tend to look at obesity. Again, it's an illness, but where we're looking at what are the impacts of excess weight on life expectancy and things like that. And so it's not always a question of, the number is above 30. Sometimes even when the number is over 25, we don't call people obese, but we might say, hey, listen, you have a little bit more of excessive body fat in certain areas that we may want to address. And again, we're always trying to be proactive, but we can say, hey, listen, let's address this first before the problems arise. Again, one of the other ways you can define it is that it's a multifactorial disorder with question of energy balance. So, caloric intake and output. It's a complex thing when you start to look at what weight gain and obesity, what's contributing to that. It's pretty complex. Fortunately, there are some things that are, and especially with medications, that we're able to do that can help with moving the fulcrum in a positive direction. But again, we're looking at a really complex neuroendocrine system and metabolic systems that are regulating energy intake, predominantly through eating, energy storage, which is predominantly fat, as well as there's a couple of other ways you can store energy in muscle and the liver, and then energy expenditure. And so when we are trying to address obesity and weight gain, we're typically trying to hit as many of those three things. So we're trying to look at, okay, what can we do to modify intake or eating? What can we do to modify what you're doing as far as storage? And what can we do to help with energy expenditure, right? And so ultimately, it's an imbalance between energy intake and energy expenditure. Genetics, unfortunately, do play a role. And so whenever you see obesity running in families, what that tells us is that there's potentially a genetic component. We can't do much to change genetics, but at the same time, there are modifiable risk factors. There are environmental risk factors that those people are being exposed to that's led to that genetic expression. So when you start to look at regulation of energy intake, the brain is the main regulator of energy intake. It's what drives us to eat or not. So it is the master controller of that. Specifically, there's a part called the hypothalamus. So the lateral hypothalamus is responsible for regulating appetite. Interestingly enough, and they've never done these studies in humans, but interestingly enough, if you were to destroy the lateral hypothalamus, you would actually lose the drive to eat. It would lead to starvation and death. The ventromedial part of the hypothalamus regulates satiety, right? If you destroy this part of the brain, that's one pathway by which you can get obese, because you never get satiated. And the question for a lot of people, especially when they start to gain weight, is there something that's happened environmentally that then caused the ventromedial hypothalamus to not work as well? And there's a lot of hormones that tend to play a role in that. Lifestyle does contribute to how those hormones are produced, and as we shall see. When it comes to regulation of energy stores and energy balance, again, it's a pretty complex neuroendocrine modulated system. It is relying on a number of either fat-derived or gut-derived hormones. And so one of the things I always try and tell patients, whenever we think of the fat cells or fat as a storage unit, it's actually a metabolically active organ. Fat is not it's not just a store that's kind of just in there. There are actually a lot of hormones that are being produced, a lot of them that will help with either weight loss or weight gain. And so again, some of these hormones or peptides fall into either the orexigenic. So when we talk about orexigenic hormones or peptides, those are the ones that promote weight gain. And there are times when those are appropriate that you want to have those on. Then you have what are called the anorexigenic factors, and those are the ones that promote weight loss. And so whenever we are trying to work with patients, a lot of the mechanisms that are being employed by the medications that we use are in the anorexigenic category of things. So these are some of the common anorexigenic hormones and orexigenic hormones which stimulate feeding. And the big ones are melanin concentrating hormone, GABA, growth hormone releasing hormone, and ghrelin. So ghrelin is an important one to keep at the back of your minds, because some of the medications that we use actually are trying to target what this medication or what this hormone is doing. Common anorexigenic factors, and those are the ones that inhibit feeding, include corticotropin releasing hormone, TNF alpha. The one I want you guys to keep at the back of your mind is GLP, glucagon-like peptide, cholecystokinin, serotonin, and peptide YY. Actually, peptide YY, I believe, is released in the gut system. Serotonin, again, is one of our big neurotransmitters. This is again, it's a big neuroendocrine transmitter. It has been implicated when the levels are low, has been implicated in depression. And so again, in patients who are depressed, as they are gaining weight, is it a combination of decreased serotonin, or is it a combination of them trying to eat to help promote serotonin? We're not sure. Again, pretty complex mechanisms. So again, like I said, important gut hormones. So like I said, there are some hormones that are being produced in fat cells or fat tissue. There's some that are being produced in the GI tract. PYY or peptide YY is secreted by the GI tract, and it helps reduce food intake. Again, it falls into that anorexigenic peptide category. CCK is another one, cholecystokinin. It's secreted by the duodenum. Again, that's part of the small intestine after the stomach. And this actually helps decrease both meal size and duration of the meal. There have been factors that will tend to blunt the response of this in people. And when that response is blunted of CCK, you will typically end up eating a lot more, and potentially the duration of the meal ends up being a lot bigger. But again, CCK is an anorexigenic factor. Now, ghrelin is secreted by the stomach, but unlike the first two, it is actually one of the ones that that promotes food intake behavior. And so when you have things that dysregulate ghrelin, i.e. Things that increase ghrelin, you'll be hungrier more often, you will have more of an increased drive to eat. Leptin is a honorable mention peptide that plays a role in this whole cascade. It is secreted by adipose tissue. So again, adipose or fat tissue, like I said, is not tissue that's just sitting there doing absolutely nothing. It is a pretty active organ. Leptin happens to be one of the things that that is produced by that. And it's going to go again and act directly on the brain in the hypothalamus. And it's actually working on both sides of the brain that regulate both hunger and satiety. So the ventromedial hypothalamus and the lateral hypothalamus, right? Both of these parts of the brain. And it's interesting how it works because it's actually on different parts of the brain with opposing actions. But the overall effect is that leptin will be released in an overfed state. So if you've eaten, you have enough calories that have come in, your fat cells will then release leptin, and this will then decrease food intake, right? It also leads to increased energy expenditure and leads to weight loss. Now, a lot of what happens with a lot of people as time goes on is they actually start to become what's called leptin resistance. And you might have seen that along the way. When you are leptin resistant, even after eating in that fed state, your fat cells do not produce leptin, or your body is no longer sensing the leptin. And so it's like, hey, we haven't really eaten, food intake goes up, energy expenditure goes down, weight gain goes up, right? And so some of the things that we have available, some of the medications actually do help with that leptin cascade as well. Leptin also acts on the cells in the liver and the muscle, leading to utilization of fat cells for energy production. Like I said, a lot of places we tend to think of energy being stored predominantly in fat cells, but muscle and liver also tend to have that. Interestingly enough, leptin also acts on the certain parts of the immune system, and so it can be pro-inflammatory. Again, inflammation is not always a bad thing, depending on which part of the immune system is being activated. Overall, leptin can also help decrease insulin, and actually that's a good thing because one of the fundamental issues with prediabetes and diabetes is that we have become insulin resistant. We are producing way too much insulin, and so any mechanisms that can help decrease insulin is actually a good thing. Leptin will help with decreasing cholesterol and triglyceride levels, along with increasing HDL levels. So essentially improving that cholesterol profile. So pharmacotherapy for obesity. Again, we are all here to learn a little bit more about some of the things that we do. So there are a number of mechanisms through which weight loss drugs typically tend to act. There are multiple mechanisms that have been hypothesized as far as how weight loss drugs work. Over the last 20, 30 years, there have been a number of medications that have come out. We looked at the mechanism, we're like, this is a great mechanism. One of them, I think, worked on cannabinoid receptors as being a mechanism by which we can help with weight loss. A lot of these drugs were pulled off the market due to cardiac risk factors. I think PHENTERMINE happened to be one of those. There's a couple of others that I'm blanking on that I think one of the ones that was working on the cannabinoid receptors actually increased suicidal risk by quite a bit, and so they ended up being taken off the market, right? But overall, most of the medications tend to work along the central nervous system to help with appetite suppression, right? Now, there are some nuances in terms of of what different drugs do. Some of the newer class of drugs will also act a little bit more in the periphery, working on the fat cells themselves, as we shall see. So like I said, central nervous appetite suppression drugs acting in the central nervous system, again, the brain. And really what they're doing is they're modulating, it's through the what we call monoamine neurotransmitters, right? So serotonin, epinephrine, norepinephrine. Specifically, a lot of them, what they'll do is they'll inhibit or prevent the reuptake of norepinephrine, thus allowing it to stick around a little bit longer and act, which is very similar to what a lot of our antidepressants are really targeted at doing, right? A lot of our antidepressants are targeted at norepinephrine reuptake inhibition. So one of the medications that's been around for a really long time, and I believe phentermine was approved, it's probably been close to 20 years that phentermine has been approved for weight loss. And the way it works, again, it's a central acting medication. It is working by inhibiting the reuptake of norepinephrine and 5-HT. Again, we're enhancing the neurotransmission of these neuroendocrine hormones. But phentermine, happens to be a stimulant as well. So we have a lot of patients who take phentermine. It is limited because of the stimulant effect. Sometimes that can worsen anxiety in some patients. Sometimes that can cause issues with sleep disturbances. Again, it works for some patients. Any patient who has underlying known cardiac issues probably shouldn't be on phentermine, and that's because of the stimulant effect that can then affect cardiac physiology. But again, it's a great medication. It's typically a once-a-day medication taken early in the morning. Again, because of the stimulant effect, sometimes we'll have patients take this and they're like, oh, wow, I'm actually concentrating and I'm actually getting through my day pretty well. And again, that's partly because of that stimulant effect of the medication. Big side effect for those who are able to tolerate it is it does cause dry mouth. In 2012, the FDA approved a medication called DYSMIA. So DYSMIA was phentermine combined with topiramate or Topamax. Topamax is a medication that we use quite a lot for mood disorders and things like that. Interesting enough, topiramate has been shown to modulate GABA. And a couple of slides ago, we were talking about orexigenic factors, GABA being one of them. If you can go in and modulate what that receptor is doing, you can impact that neurohormone and actually help with it being more of helping with weight loss. Again, so this is a combo. I recently had a patient who was on phentermine, max dose on that. We just added topiramate. It's a lot cheaper to take them separately. It's a pain to have to take two medications versus one. I think DYSMIA tends to, if you can get it approved, it's probably, I think, about like $150 to $200 a month. Phentermine on its own is about $10. Topamax on its own is about $10. So $20 for two meds or $150 to $200 for one. Belviq was another medication that was approved by the FDA in 2012. Belviq is another centrally acting medication, so it doesn't have any stimulant modalities to it. Again, it's acting on those 5-HT receptors. Again, trying to modulate norepinephrine, epinephrine, and serotonin. But because it's a little bit more specific to some of these receptors, we actually have to be cautious with patients who are already on any antidepressant drugs because we could cause something called a serotonin syndrome, which I always thought was just something clinical. I have now seen it in practice twice. Now that patient was on a lot of medications that increased their serotonin, and then they also had a procedure where they had anesthesia, and anesthesia can actually potentiate the effects of some of these medications. But again, yes, how often have I used Belviq? Maybe once or twice. Again, the big limiting factor to Belviq was cost, and because of how it works, some patients were like, this medication made me feel a little too numb, and so that was one of the reasons we did not use it. But again, it's out there. Again, it's still pretty pricey, even though it was approved more than 10 years ago. CONTRAVE came around in 2014. CONTRAVE is a combination of two medications, naltrexone and bupropion. Naltrexone, if you're not familiar with it, you may have heard of a medication called Narcan. Narcan is actually what we use to reverse opiate overdoses. And so what naltrexone essentially would be doing is working on certain opiate receptors in the brain. Turns out when we actually start to modulate and block some of those, some of the sugar addiction patterns that a lot of us have that end up leading to weight gain end up being blocked. And so again, like I said, obesity and weight gain are such complicated things. There's definitely a sugar addiction component for a lot of us. And so naltrexone seems to work on those areas. Bupropion or Wellbutrin is working to reuptake, to increase the presence of dopamine and norepinephrine in our brains. Again, dopamine, our happy hormone, norepinephrine, again, being one of those neuroendocrine regulators that can help potentially with weight loss. Again, any limitations to any medication that is impacting dopamine and norepinephrine is, okay, what are the psychiatric or depression medications is the patient on? Number one. Number two, because of the naltrexone in there, you kind of have to limit it with patients who have active opiate use disorders, active alcohol, although active alcohol disorder is not a contraindication. Active opiate use disorder is definitely a contraindication. Uncontrolled hypertension and anyone who has seizure disorders, you want to be careful. Now, I think that the future of weight loss is going to be these next class of drugs that we talk about. And in part because of all the different things that they help with. So GLP, glucose-like peptide, if you recall a couple of slides back, we're talking about anorexigenic factors. GLP is one of those. And so GLP-1 agonist, an agonist is something that kind of looks like it and will actually attach to the receptors, essentially giving you the same response as GLP would. And so the first GLP drug was that was approved for weight loss was actually liraglutide in 2014. Although as a class, these medications have been around since, I remember being in residency in 2009 and starting to see these being used for diabetes. So they've actually been around for quite a long time. But the first time one was actually approved for weight loss was liraglutide in 2014. It also goes by the name of Victoza. And again, has been used pretty successfully. Now, the issue with GLP-1s as a class is that they are injectables. There is a new oral formulation that's come out. I haven't used it for weight loss, so again, I do not know how effective it is. But for the most part, they are injectable. Liraglutide was a daily injectable medication. Semaglutide or Ozempic or Wegovy, so same drug, just different dosing, but semaglutide was approved for weight loss in 2021. I believe it was approved for diabetes way before that. Again, these medications were initially developed for the treatment of type 2 diabetes and have been extremely effective, almost to the point that I think very soon they're going to be the first drug we go to for people who have diabetes because they have just been so effective. The other cool thing about your GLP-1s is that they not only impact diabetes and blood sugars, they are helping with they're going to help with, to a certain extent, energy expenditure. They're going to help with what we're doing with storage of glucose into fat cells, and some of your newer drugs are actually being shown to have cardiovascular benefits, which is amazing. Again, so these are still major players in treating type 2 diabetes. Semaglutide again works by mimicking the action of the hormone GLP-1 in the body. GLP-1, as noted on one of the prior slides, is an anorexigenic factor. Again, it helps regulate blood sugar levels, reduces appetite, and slows down gastric emptying. What that's going to do is your meals are going to get smaller, and you're going to start to sort of space out your meals. Again, things that we want to do to help with, again, like I said, it's three things you want to help with. You want to help with intake, you want to help with storage, and you want to help with energy expenditure. Again, you can already see that we're trying to impact intake with reducing appetite. By activating the GLP-1 receptors, agonists like semaglutide, liraglutide increase satiety in the brain. So it's not only decreasing appetite is actually helping with satiety. So you actually get full, and you actually have, you reduce hunger and you promote feelings of fullness. The limitations in their use really come down to nausea and vomiting. Oh, good Lord, I have a lot of typos in here. So nausea and vomiting are your two limitations. Now, whenever we start patients on this medication, I have learned to tell all my patients, expect nausea, hopefully no vomiting, because approximately 95% of patients will have nausea. Now, you can mitigate nausea by decreasing dose. You can mitigate it by using Zofran to help with the nausea. We've also found that smaller, more frequent meals and lots of hydration can seem to help. And decreasing fatty meals will also help with that. In the studies, some patients were noticed to have developed pancreatitis. We haven't seen that happen. I don't know of anyone who's seen that happen. Now, anyone who has a history of pancreatitis, you kind of want to watch out if you're going to use this medication. The only contraindication is somebody who has a history of specifically medullary thyroid cancer or has a history of what we call multiple endocrine neoplasms type 2. I have met a couple of patients with medullary thyroid cancer. I've never met anybody with multiple endocrine neoplasms. Never have. But again, just something that we always try and take a look at. And then the newest kid on the block is TIRZEPATIDE or Mounjaro. So the difference between semaglutide and TIRZEPATIDE is that TIRZEPATIDE will act on the GLP-1 receptors, just like semaglutide, but it's also acting on what we call glucose-dependent insulotropic peptide receptors. So there are a couple of other additional pathways that it's acting on. GIP is an intestinal hormone with a broad range of physiological actions. In the fed state, it actually stimulates insulin secretion. And during, when your glucose levels are either normal or low, it'll stimulate glucagon secretion. What this means is that in the fed state, what's going to happen is that, and insulin has a lot of roles that it plays. Insulin is typically the big baddie in a lot of this, but in some cases, you actually do want insulin to work effectively. And so when you've eaten, you want to have an appropriate insulin response. It's going to help with that. And then when you start to get hypoglycemic or your blood sugar start to drop, again, you want to be able to regulate where your sugars are at so that you don't crash or you don't get famished. And so again, for a lot of us, we have plenty of stores, right? We have plenty of stores in the liver and the muscle and in fat cells. And so typically what it'll do is when those blood sugars start to drop, we're actually going to increase the glucagon secretion. Glucagon is one of the hormones that's responsible for increasing our blood sugars back to normal. And so, you can wait a little bit longer before you get to that meal. So essentially, those are the broad categories of medications that we tend to use. Again, I know there's a bunch of new medications on the horizon, but I really wanted to leave off with just what we have found to be pillars of weight loss. And this is actually taken from a lot of our most successful patients. We were not necessarily doing this in the beginning, but as we start to see patients start to become really successful, like, hey, what are you doing? Oh goodness, okay, what else is happening that has promoted you to lose weight and maintain weight loss? So one is restoring insulin sensitivity, and interesting enough, your GLP-1, so your semaglutide, tirzepatide, will help with that. Metformin is a much older drug that has kind of fallen out of favor in terms of managing weight. There are still some indications where we use it. We most certainly use it still for our type 2 diabetics. There's some interesting data coming out on metformin and longevity. And so I have some patients actually taking it for longevity. Its limitation is it can cause diarrhea. And then berberine is just an over-the-counter supplement that can help with increasing insulin sensitivity. Number 2 is restoring youthful hormone balance. So what we've started to do with a lot of our patients who come into the practice is we say, okay, you know what, you want to lose weight, fantastic. We'll put you on a medication. But while we're doing that, let's also take a look at some of these hormones, specifically testosterone, estrogen, progesterone, and thyroid. And let's figure out a way to optimize these as best as we can, because we know it's actually going to lead to meaningful weight loss and maintaining that weight loss. So a lot of our most successful patients, as far as who've used semaglutide, are also on testosterone predominantly, and then eventually estrogen and progesterone. If they're women, potentially some thyroid hormone, and then for men, it's testosterone and thyroid. Now, one of the most interesting things I always tell people is that testosterone is such an important hormone, even in women. And we actually have more women in the practice on testosterone than men. Third is controlling the rate of carbohydrate absorption to prevent insulin spikes. And this is a strategy that a lot of people can do. If you increase the amount of fiber you have in your diet, you will naturally slow down the breakdown of carbohydrates. You will slow down the rate at which you absorb those, and you'll prevent insulin spikes, which invariably cause glucose crashes, which then lead you on to the next sugar rush. Or you basically chasing sugar rushes if you're going up and down, up and down. Increasing physical activity. So I always advise most of my patients, that weight loss should at least take 8 to 10 months. Honestly, most patients get that goal a lot faster. But setting up the expectation that it's going to take that long, in my mind, is that we're hoping and we're planning that we will slowly start to work on increasing physical activity. Because again, it's all the things that you start to do today while you're losing weight that are going to maintain the weight loss once that's off. And so I really don't care what the physical activity looks like. If all you ever did was sit on a couch all day, fantastic. Let's get you up and walking. How long? Whatever you can tolerate. Again, as long as you're constantly improving and increasing, that's really the ideal. So, the gold standard is 30 minutes, 5 days a week. Most people will initially have a hard time getting there, and that's okay. But if in a year, 2 years time, that's where you're at and that's what you're maintaining, fantastic. Again, this ends up being a marathon, not a sprint. Restoring brain serotonin. Now, I haven't done a lot of this in our practice, and I may have to look at this in terms of trying to restore serotonin and seeing if that impacts things in our patients. But again, easy way to do it is there's some supplements of tryptophan that you can take. 5-hydroxytryptophan is another supplement that you can take that can absolutely help with that. Restore basal metabolic rate. Now, the interesting thing about basal metabolic rate, so we're talking about energy expenditure, right? So energy expenditure is, activity. Activity will do that. But when your basal metabolic rate is high, it means that you are still at a pretty high metabolic rate when you're not active. Now, one of the ways you can do that is, believe it or not, activity. The more active you are, the higher basal metabolic rate will be. But interestingly enough, there are studies that have been shown that caffeine can help with that. Again, you have to be careful with caffeine, and it's really small amounts of caffeine, right? So you have to be careful with what you're telling patients as far as caffeine. Caffeine can be a double-edged sword. ECGC, or green tea extract, is another excellent supplement that you can potentially add to help with that. There is one called ECGC that has a combo with caffeine that can absolutely help with that basal metabolic rate. Restoring healthy fat cell signaling, so impacting leptin and adiponectin levels. Again, a lot of the medications that we use, including phentermine, semaglutide, and tirzepatide, actually, as well as metformin, actually do that. And then eating to live a healthy and long life. Patients always ask, hey, listen, what diet should I be on to help lose weight? And I try and advise my patients to not necessarily pick something that's restrictive. I want them to find a healthy way that they can eat for the rest of their life. Because again, once we stop the medications in a year, if what you're eating, you can't sustain that, you'll just go to your old habits and the weight will come right back up. And so I like the Whole30 as a framework for a lot of people to look at. It's a really good anti-inflammatory type diet. The Mediterranean way of eating is another way that you can, potentially start to look at. We have patients who go plant-based and they do fine. Now, again, with plant-based, you really have to dial in a lot of your other nutrients and things like that. But we have patients who do plant-based nutrition and are doing fantastic. Again, I have met people who are plant-based and all they eat is McDonald's fries. That's a problem, right? And so, again, it's finding what will work with your lifestyle, what you can sustainably do for the rest of your life, right? And so that is the last pillar of yep, I believe that is the end of my segment. Okay, yeah. So, alrighty, so I'm starting to see questions. So let me see, does a question chat bar have? Nope, it does not. So I am looking at this first question. Okay, yeah, Rick. Do you feel like most medications for weight loss have have been used for life, or the weight will come right off. Do you? Yeah. So the weight loss medications, what I find is that because weight loss is so challenging, and a lot of people, by the time they come see us, they're like, I have tried everything, and they're pretty discouraged. The weight loss medications give us a really quick win for a lot of patients where we can say, hey, listen, and again, I always temper the expectation. I was like, the goal is £1 a week, right? Again, and I think we have this distorted view of weight loss, thanks to shows like The Biggest Loser, right? Where people are losing, 30, 40 pounds in a week. The reality is, they're doing absolutely nothing but training all day, eating and sleeping. That's not your life. I mean, that might be your life. That is most certainly not my life, right? And so I try and temper patients' expectations by saying, this will probably take a while. Let's shoot for £1 a week. I had a patient that we checked in with yesterday, and in 2 weeks she's lost 5 pounds. And she answered the phone very, very saddened. And I was like, "What's happening?" I was like, "This weight loss thing is not going well." And I was like, "What's your weight at?" And she's like, and so we calculated it. And it was like 5 pounds in 2 weeks. And I was like, so when you think about 5 pounds in 2 weeks, that's 10 pounds a month. In 3 months, that's 30 pounds. And so again. And when I told her that, she's like, oh, yeah, okay. I guess I'm actually not doing too bad. So again, the weight loss medications really do help potentially give us that initial win where patients can be like, ooh, okay, I can see the weight coming off. And then they get the buy-in to do the hard stuff, which is the lifestyle changes. Alrighty. Any other questions in the chat? Okay, I think I see a question here. Alrighty, so somebody said, since I entered menopause, I can't lose weight, can't get satiated. I'm hungry constantly with extreme cravings for sugar, like I've never experienced before. I'm already on phentermine 30 milligrams daily for that reason, for reasons that are not weight related. Also Wellbutrin, but neither have helped at all with the weight loss. What medications would you recommend to resolve these issues? Well, actually, so the first question is, so one phentermine, the max dose is actually 37.5. You can go to 37.5. Wellbutrin is a great addition in there. I'm assuming it's probably been used for totally different things. So the question would be, one, to max out potentially the phentermine dose to 37.5 if you can tolerate. Two is to actually go back and take a look at some of those hormones. Now, not every patient that we see wants to go on any hormonal optimization, and by hormonal optimization I actually mean replacement if you're in menopause, right? And so we'll usually say with patients, educate them as to why we think that's a good thing to do. But again, that's not always the case, and some patients are like, you know what, I don't want to do hormones, for whatever reason, and we're like, fantastic, okay, no problem. But we still want to potentially take a look at lab work. We want to take a look at where the insulin levels are at, because if they have an element of insulin resistance, maybe an addition of something like metformin would be great for them. Or just going all the way to semaglutide or tirzepatide, Mounjaro, would be a great option. Also potentially looking at where the thyroid is at. So again, if they have thyroid that is a little bit, hypothyroid, that will start to impact things. And so you do want to potentially either with nutrients, optimizing thyroid, or actually giving patients some thyroid hormone. So hopefully that answered that question. Okay, so let's see. What role does sleep play in maintaining healthy weight? Man, so I'm actually going to have Dr. McCallum do a talk on sleep. So she's a sleep person. So if a lot of you who have interacted with her know, she does a lot with nutrients and sleep. And so that's her jam. But sleep does a really interesting thing. If you were to take somebody and potentially sleep deprive them for a couple of days and start to check their blood sugars actually look like diabetics. You actually start to impact insulin regulation. You actually start to become a lot more insulin resistant and start to impact what your body then does with glucose, i.e. you'll actually start to store it if you sleep deprived long enough. And we think the mechanism that this works by, I think there's possibly a cortisol component to it. I would not be surprised if there were a couple of other neuroendocrine things that might be playing a role in that. Yeah. So sleep is definitely, and yes, I should probably put that as one of the pillars, is trying to ensure adequate sleep. Now, again, I've come across folks who do well with 4 hours. I have come across folks who do well with, 8 to 10. And so there's no, I guess, correct sleep amount. It's what might be right for you. So hopefully that answers that. Let's see. Okay, so we have, does weight loss tend to reduce organ fat like non-alcoholic fatty liver disease in the same ratio as external? That is actually a really good question. So actually what I'll do is I'll project these questions, project, so you guys can see the questions. Okay. So one of the interesting things about non-alcoholic fatty liver disease is for a long time, we just, would do ultrasounds. We're like, oh, people have some fat accumulation in the liver. It's a benign condition. Now we actually know that it's actually the leading cause of liver cirrhosis, followed by alcohol. Alcohol used to be the leading cause of cirrhosis. Now it no longer is. Non-alcoholic fatty liver disease actually is, right? And so we know that when you start to re-regulate insulin and starts to help with fat loss, one of the things that actually starts to improve pretty quickly is non-alcoholic fatty liver disease. Now, I do not know whether it's in the same ratio as, the loss of the fat is going to be the same as external or, along the skin. So actually, I have no idea. I will have to take a look at that. So actually, let's go ahead and put some of these questions on here. I think I answered some of these. Can you talk metformin a little more when you say it is used for longevity? What does that actually mean? Yeah. So there are a couple of theories as far as why we age and how we age. So the thinking is that with every replication of a cell, right, you're transmitting information from this cell to these two cells, right? So let's take, for instance, a muscle cell and how we replace it, right? So this muscle cell is going to die, but before it dies, it's going to replicate and produce another one. And you're going to transmit that genetic material across from this cell to that one. Now, you can only do that for a certain amount of time before you start to degrade their information that's being transmitted from cell to cell to cell. And that's where we think aging starts. That's one of the theories of aging, is that as we start to decrease the amount of or how well we transmit that information, the external result is aging, right? We just don't replicate as well as we were before. Metformin is one of the things that has been implicated as helping with lengthening of what we call telomeres. And telomeres are those things that are at the ends of our DNA. And the longer your telomeres are, so telomeres, think of this chain of information. And on both ends, you have this nonsense information. So the nonsense information is really not being transmitted. It's information that's in between. Now, every time you replicate, the nonsense information gets smaller, 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 and smaller, right? Eventually, you get to the point where you're starting to sort of eat into the data that you're transferring to the next cell or to the next generation. So if you can keep your telomere length really long and stabilize that, you could potentially have a cell that's immortal. So that's what that means. Recently, I've been on Ozempic for my type 2 diabetes. It's working great for my blood sugar, and I have lost needed weight. My question is there things it's doing negatively to my body? So a lot of your, okay, so we'll just talk about these. Your GLP-1s as a class drug have actually been, like I said, have been around for, since at least 2009. And so we have a lot of great data as to what these medications are doing. Now, there are certain, like I said, there is a potential for some thyroid stuff, like thyroid cancers. Again, it's patients who have a history of medullary thyroid cancer or certain cancer syndromes in the family. There is a risk for pancreatitis there. There is the risk for gallstone development. Long-term, so to date, we haven't seen any long-term issues associated with these medications. As always, the hope is that we can start to reverse some of these conditions, right? So no meds is better than meds. Use of some meds is better than disease process. And so it's a spectrum. So you go from you're losing weight, your type 2 diabetes is controlled. Okay, what else can you start to layer on top of that, on top of the weight loss? Okay, you're starting to eat better, you're starting to, improve your lifestyle, you're starting to do all these different things. Eventually, you can actually get off these medications. And, sort of as a testament to what can happen, we have actually Dr. McCallum has a patient who joined the practice, had an A1C of 11. For those of you who do not know, A1Cs are a way that we can check and monitor how well diabetics are doing. 11 is a pretty horrendous A1C. And with lifestyle changes only, was able to get his A1C down to, I believe, 5.6, which is no diabetes essentially, within a span of 6 months. And so just decided, is like, this is not going to be part of my life. I'm going to make all the necessary changes. And so the medications are there to help you along the way. I mean, again, for a lot of people, unless, so for instance, with diabetes, unless your pancreas is no longer working, it is a reversible disease. Okay, so can someone who doesn't have type 2 diabetes use Ozempic for weight loss? And if so, are there any interactions with Wellbutrin? So let's project this question. I want to say that probably most of 90% of all Ozempic patients are not diabetics. And so, yes, you can use it. I do not see any contraindications with using it with Wellbutrin. So it's working on different pathways. There shouldn't be any interaction whatsoever. So yeah, and again, like I said, most, like 90% of our patients who are on Ozempic are actually not on, they're not diabetic. They're just using it to help with getting to their weight loss goal. And, to that point, a lot of our patients we do have some patients who have that clinical diagnosis of obesity, their BMI of over 30. A lot of our patients actually are not, so we'll have patients who come in and say, hey, listen, I know my BMI is not at 30, I'm maybe at a 27, right? But there's diabetes in my family, there's heart disease in my family, and I've just gained like these, 20, 30 pounds that I'm really having a hard time losing. I want to get back to my ideal weight. And I tell them, okay, fantastic, let's go for it. Why wait for diabetes to come on board? Why wait for heart disease to come on board before you do something? Okay, so what is good fiber? Good fiber is essentially you're looking for fiber that is you have soluble and non-soluble fiber. You want to find fiber that is non-soluble, i.e. you will not break it down, you will not digest it. So for instance, I'm thinking potatoes have fiber, but for the most part, potato fiber is soluble. And so you'll end up breaking it down and utilizing it. Things like a lot of your veggies, like your green veggies, tend to typically have non-absorbable fiber. Psyllium husk, which I think comes in a supplement as well, is a non-soluble one. So those that's what we would term as good fiber. So i.e. fiber that will not be broken down and converted into carbohydrates is good fiber. Okay, question here. Okay, so I believe we have, let's see, did we answer all the questions? 2, so yeah, I think. Okay, I think those are all the questions that were asked. Oh, wait, did another question pop up? I believe I've answered all the questions. Yeah. So, like I said, thank you all for coming. What I'll do is, this was recorded. I'm not sure how it's going to look like, after, but I will give you guys the link to this thing. And next time, I'm hoping. Oh, wait, another question. Real quick. So how long would you need to be on Ozempic just to lose weight, or do you have to be on it to maintain weight? Okay, excellent question. It depends on, number one, how much weight you have to lose. Again, I encourage my patients to think about a pound a week. Often it's more, but a pound a week, right? So you can sort of extrapolate that out. If you have 10 pounds to lose, think about it as being 10 weeks, 20 pounds to lose, about 20 weeks. It may be a little bit faster. Now, I often want it to be a little bit longer because, again, it's going to take that long to get those habits. You do not necessarily need to be on Ozempic. You don't not need to remain on it to maintain, as long as you're doing the things that you need to be doing. So your lifestyle has been dialed in, you're eating correctly, you should not eat it. And as long as we have corrected things like hormonal abnormalities and imbalance. Again, menopause just by its state is going to be a state that results in decreasing metabolism and increasing weight gain. And so as long as people understand that, okay, we'll be able to get, if we're doing nothing about your hormones, fantastic, we'll get your weight down. It might start to creep up, in which case you may want to get back on it. And we have a number of patients who, lost their weight, have been off it for, 6 to 8 months, and then went down to Mexico and had a good time and started to gain the weight back again. And so they go back on it, lose. And so again, we're trying to individualize things. Again, like I said, no meds is the best. Meds with no disease, it's fantastic. It's better than having disease process. Okay, so I think I answered all the questions. Like I said, I will email this out to all the attending people, and also those who signed up. You can probably feel free to email me back if you guys have questions. It may take me a while, and what I'll do is if there's a lot of similar questions, it may just be easier for me to just shoot a couple of quick videos and get that. Awesome. Well, guys, thank you very much. I'm hoping to potentially do these once a month, where I can just pick a topic and just open it up, and so if you guys have any topics that you might want to talk about, I know sleep might be one that we might do. I might have Dr. McCallum do that. We might also do one for hormones. So we do a lot of hormonal optimization. So I might actually do one of those. And so again, if there's any topics you guys think might be useful or that you want to hear about, feel free to send me an email. Awesome. And since I do not actually see everybody's faces, I will assume that we are all doing fantastic today. You guys go out, have a fantastic afternoon. Have yourselves a wonderful weekend. And again, if you guys have any questions, email those to me, and I will shoot those. I should be able to shoot out this video recording sometime later on today or tomorrow. All right, guys. So stop recording.